that we're going to cover coming up. And I just feel that it's better if you're tested and educated on each individual topic. Um, and again, I'm not going to go crazy on it. So let's pull this one up. So one of the things that I wanted to hit on, because these are some things that you can be tested on. When we talk isotonic, hypotonic, and hypertonic, these are often going to be referred to as an isotonic solution, hypotonic solution, and a hypertonic solution. So when you hear isotonic solutions, this is a solution that allows equal parts of fluid to move in and out of the cell. Hypotonic is usually when the cell is, we're going to say, swollen, and we're trying to pull all the fluid into it. Hypertonic is not usually, it's not a very common thing, actually. When we talk hypertonic, a lot of the times this is where we're trying to induce third spacing. So our cell is so fluid filled and we're given a hypertonic solution because we're trying to pull everything out of the cell and induce third spacing. So the fluid is pulled from the cellular space to the interstitial spaces. And that way, um, we can, have the body start processing the fluid out in other manners. So isotonic is the solution that you're going to be giving. But for testing purposes, remember, isotonic is equal parts in and out. Hypotonic is where we're trying to pull all the fluid cell or all the fluid from around the cell into the cell. And hypertonic, we're trying to pull the fluid of the cell. So one of the test questions that you could see is what type of fluid solution would we be giving if we're trying to induce third spacing? And the answer to that is a hypertonic solution. Um, so we'll talk about the sodium potassium pump for a minute. Um, Mainly on the potassium side. But our body needs certain parts potassium, certain parts or certain parts of sodium, and certain parts of potassium to maintain homeostasis, to keep everything normal and keep everything balanced. So our sodium potassium pump, just I want you to think of it as a protein on a cell membrane that keeps ions at proper levels inside and outside of the cell. So your potassium is a intercellular, and your sodium is an extracellular. So they're cations is the way that you'll see them listed here. But what I want you to remember is we have to have the correct amount of each. Too little or too much, and we can throw our body off. When we talk too little or too much potassium in the body, we start to get rapid changes. You can get EKG changes, you can get blood pressure changes, heart rate changes, breathing changes. This can throw you into lethal arrhythmias and can kill you. We often see this in our dialysis patients. If they miss too many treatments of dialysis, you often worry about a patient being hyperkalemic, which means too much potassium in the body. As an advanced, there's really not much you're going to do for that. On the medic side of things, we can see the signs and symptoms and see the EKG changes and start loading them up with albuterol treatments and calcium and all these other things. And it's not something that happens a whole lot, but we do see it. So I always tell people, and you're going to probably unfortunately hear this a lot more as we go through class, but it is always easier to find a reason to ALS a patient. 99.9% of the times, dialysis patients are ALS patients, especially when they've missed dialysis treatments. If you have a patient who's missed usually more than, I'll say, two or more dialysis patients, and you need to be ALSing them. They need to be on a cardiac monitor. If they have the veins for it, we should be establishing an IV. We don't usually run fluid on these patients because they already have a hard time processing fluid, but we try to get some of the ball rolling for the hospital so when we get there, they can get labs and they can start treatment if needed. Or, if you do get a patient and they are very symptomatic from the dialysis that they missed and you're getting a medic intercept somewhere, then you're able to have a lot of the basic stuff done, IVs, initial 3 and 12 lead, all of these kind of things. Potassium is a very, I always called it a very finite level thing. A lot of systems say 3.5 to 5 is the ideal range for potassium. I've worked in some systems where it's, maybe 3.5 to 5.2. But for all purposes, in our general area, 3.5 to 5 is the acceptable range. When you exceed the 5, you're becoming hyperkalemic. When you go below the 3.5, you're becoming hypokalemic. And again, it's something that we need to ask our patients. And it's often one of those questions, if you see your patient on a potassium supplement, you could also bet that they're, especially the older population, that they can even be on what we call Lasix. So that often is an indicator of congestive heart failure. They're on Lasix to try to push the fluid out of the body. Well, the more that you pee and the more fluid you process out of the body, the more potassium you push out of the body. Our elderly population, the older they get, sometimes the more confused they become. So we really have to watch that the medications that they take. I had a lady who was getting generally confused and was taking her day and nighttime meds at the same time, um, because I was in the same tray. Well, her daughter would come and would fill her medication trays. Well, she was overdosing herself on her potassium. Instead of taking uh, one tablet twice a day, she's taking 4 tablets a day because she was taking her morning and night together, and then she's taking her morning and night off of the other tray because she thought that's how it went. So again, it's one of those finite things that we really just need to be cautious of. It's also why we like to look at medication lists. We look at past medical history, things of that nature. So one of the other things that we want to talk about when we talk sodium potassium pump is the sodium potassium pump requires energy. And we're going to talk about this needed energy here shortly, but it needs the energy um, to pretty much help shift or move across the concentration gradient. So our sodium potassium pump is responsible for properly moving the sodium and potassium around. Is the best and simplest way that I can explain that. Um, but if there's not enough energy produced, then the sodium is not removed from the cell. Water enters the cell in quantities such that the cell will burst and die. So you have to have the proper amount of sodium in there to pretty much balance the amount of fluid that is within the cell. Stupid computer. So what you're looking at here is you're looking at your adenosine triphosphate, so your ATP, converting over into ADP. This is the energy exchange, we're going to call it. But this is your sodium potassium exchange pump. So we're pushing the sodium out. We're bringing the potassium in, and our energy is cycling through, and it's making sure that we're bringing our 2 cells of potassium in, pushing 3 cells of sodium out, and it's making sure that we're keeping the proper amount of fluid in and out of the cell. The last thing we want to do is bring all that extracellular fluid in to the cell, causing it to burst and die. When we start getting a buildup of the extracellular fluid in the cell, this is also where we're looking at possibly having to give a hypertonic solution to create the third spacing. So we're pulling that fluid out of the cell and pushing it into the interstitial spaces, inducing that third spacing, trying to protect the cell. So when we talk energy, energy is the work. I mean, let me try. I don't like how this is worded. So, work of the body requires energy. Energy is built upon a constant supply of glucose and oxygen. So, when you think energy, I want you to think glucose and oxygen, proper parts of both. And what I always tell everybody, because I actually had a student tell me the way they remembered this. When you think proper glucose inside the body to help you create energy, I want you to think of an unresponsive diabetic patient. They don't have enough glucose in their system, right? Well, without enough glucose in their system, they don't have the energy to function, which means that they don't have the energy for the body to work. That is the way that one of my students told me before. That's how they remembered it. And it has helped a lot of other students that way. Same thing with oxygen. If you think of an unresponsive hypoxic patient that's unresponsive from their hypoxic state, they don't have enough oxygen in the body to fuel the body. So we have to have proper glucose in the body. We have to have proper oxygen in the body. Again, that's our body working. That's the body using the energy. That is our body maintaining homeostasis. Maintaining homeostasis takes energy. Energy lets the body work. And by the energy letting the body work, it regulates the glucose and the oxygen. So it takes all these, I call it the chain links, but it takes all the chain links being put together for everything to maintain homeostasis. Because at the end of the day, everything that our body does is to maintain homeostasis. That just center state of general well-being is what we're always trying to accomplish. So we'll get into that more. So does this actually have, of course it does. So we're gonna talk more about glycolysis, glycogenesis, all of these things when we get into endocrine. So I'm not gonna hound you on it now, but I am going to start bringing up this. We have two types of metabolism that we're really gonna talk about. We have aerobic and anaerobic. So aerobic is with oxygen, anaerobic is without. So aerobic metabolism is a complex process that results in larger amounts of ATP releasing heat. So again, it's or I'm sorry, anaerobic is with oxygen, aerobic is without. That is my bad. I am sorry. So our first phase is our glycolysis. This is where the glucose is broken down into pyruvic acid, and our body uses an anaerobic metabolism. This is with oxygen. This is the front line of how our body likes to operate. So we like to use oxygen and glucose. So our glucose is broken down into the pyruvic acid, and our anaerobic metabolism helps process all of this. When we get into the second phase, so this is, our backup, our plan B, we're using aerobic metabolism. And this is a complex process that results in larger amounts of ATP being released, releasing heat. because we're trying to fuel it without as much oxygen. And if we don't get the oxygen levels back up quickly, we cause cell death and death and eventually death of the person. So our body is, I always call it the fine-tuned automobile. It has to have the right, just, levels of everything working in place. So when we start using backup systems, we can't use backup systems for very long. Again, it's all things that we're going to spend a lot more time diving a lot more in depth to when we get into, especially endocrine and respiratory. We're really going to hit these things big. Um, Unfortunately, this is just one of those stupid things that we have to go over real quick. Um, just remember pH is the potential of hydrogen. Um, your pH scale ranges from 0 to 14. 7.35 to 7.45 is the ideal where you want to be. The way that, again, the way that I remember things is a little bit different than most. But when we think of a pH scale and we think, okay, normal is 7.35 to 7.45, how am I going to remember that? Remember your end tidal. A good end tidal is 35 to 45. So just put a 7 before that, and there's your pH, 7.35, 7.45. Again, we're going to dive more in depth with this as we go through. I'm not going to hound you to death. Here. Um, the acid-base balance um, will hit briefly. It's not something, again, it's really not testable as far as registry goes. So when we talk the acidic and the alkalotic parts of the body, acidic is the concentration of hydrogen ions is high, and alkalotic, the hydrogen ions are low. Our body has this buffer system. The buffer system is when excess hydrogen ions are converted into substances that prevent acid accumulation, and that is what maintains the acid-base balance. Remember, you have to have the right acid to base. So too much acid or too much base, and our body starts operating on separate ends of the spectrum from where it should be instead of that nice 7.35 to 7.45. And then we need to cover, again, everything we refer to when we refer to the body, when we refer to injuries, parts of the body, we're always referring to the body in its anatomical position. So, anterior is the front, posterior being the back. Um, superior to inferior, superior being the top, inferior being the bottom. We know that line that runs splitting the body down the line of the armpit. That's our mid-axillary line. So you're, again, just remember when we're referring to the body, we refer to it in its anatomical position. When we get into trauma, we're going to dive a little bit more in depth into this. And I actually have a couple examples that I'll show you guys as to why we always refer to the body in its anatomical position. One of them being there was a EMS call, it had gone to court. It wasn't in our area, but the provider was describing injuries to the body, and he did that common thing that we all do at 2 o'clock in the morning. When we're looking at the patient, our right side is their left side. Well, gross deformity to the right upper arm, and he actually meant the left, and there's all these things that was wrong with the report and the way that he was describing the injuries because he was him looking down at the patient. Well, don't forget, your report is part of the patient's medical record. Well, this call ended up the circumstances that resulted in the call ended up going to court, and his report, everything he described essentially was correct, except for the positions of the body. And the problem with that was, well, they didn't hold it in court. And um, he actually ended up, the provider actually ended up having to go back through extensive training. And he actually talked about it. And I'm going to try to find the video. And he actually describes in great detail why it is extremely important for you to actually be able to remember the anatomical positions, because a lot of people don't realize. So if you look at this picture, when we talk anatomical position, our palms are facing forward. So when we talk burns and we say, oh, the anterior portion of the arm is burnt, and we get there and it's actually the back of the hand, well, from the back of the hand up, and then you just get stared at by the hospital staff. Well, that's why. It's anatomical position of the body is key for a lot of the things that we're going to do and a lot of the treatments that we provide and when we describe things. So if you remember nothing else from this chapter, remember anatomical position is key. Everything else you're going to get as we go through. Um, Lines of reference, again, mid-axillary, mid-clavicular. And then remember, for our purposes, our abdomen is broke up into four regions: right upper, left lower, right lower. So RUQ, RLQ, LUQ, LLQ. That's going to be extremely important for us to remember, because when we get a trauma patient or even a medical patient, and you have an injury to the stomach or stomach pain, and they're describing to you where the pain is at, the reason that's important for you is so that you can remember what organs lie in which quadrant. And that is something that we actually get into a little later in class. Let's see. We cover that the further we get in. So just remember, the skeleton consists of 206 bones. I don't test you on, how many bones make up this, how many bones make up that. Um, the one thing, though, that I do need you guys to remember, and we will cover this again and again and again, but long bones, where are they? Excuse me. So, our arm bones and leg bones, long bone fractures. Your humerus is the hardest bone in the, or your femur is in the right spot, just completely in left field today. But your femur is the hardest bone in the body to break. You have two of them, one in each upper leg. Humeruses are the upper portion of the arms. Your radius and ulna are the lower portion of the arms, and your tibia and your fibula are in the lower portion of your legs. Your fibula is the bone that runs on the outside of the leg. Your tibia is the bone that runs on the medial aspect of the leg. Um, your radius is the bigger bone. Of the forearm. Your ulna is the smaller bone of the forearm. So this is another good one to remember, and we're actually going to hit this again when we go into burns. But you have essentially the three layers of skin: the epidermis, the dermis, and the subcutaneous layers. Your epidermis being the most outer portion of your skin. Your dermis is the pretty much the middle layer. This is where your some of the vasculature in your arms or legs or skin. I should just summed it up with that. But what I really want to hit is the sensory receptors. They lie just under the dermis on the top of the dermis. So this is where a lot of our pain receptors are going to come from. When we get burns, especially, and we burn through this pretty much upper portion. We've burnt off the sensory receptors. The problem is now you're getting down here into the area of the nerves and the veins and the arteries. So this is where you really start having some issues. And a lot of people think that once you get through that sensory layer, you don't feel anymore. That's not necessarily the case. Um, but when you get through the dermis, this is where a lot of the capillaries, also, if you look, they're running off of these veins and these arteries, and it's what runs up and feeds the capillary beds of underneath your skin in that epidermis layer. The main vasculature lays down here in this fatty subcutaneous layer. This is something we're actually going to break down a little bit more. I forget which chapter it's in. Um, but it helps you guys kind of have a better, bigger understanding of what each layer actually does. And I know you covered it in basic school, but we covered it again in advanced school just to kind of give you an idea. Because also, you really need to be able to look at an injury and go, oh, we're down to the subcutaneous layers, or you're not necessarily going to need to know that for how do I want to put this? For everyday purposes. But oh, okay, you're going to know that, oh, all right, this is just a minor cut or minor burn. It's just the epidermis layer. So where's the skin and hair portion? Or, well, we're down in the dermis. Okay. Or, man, that's cut all the way down. And it gives you a better understanding also of the long-term effects that this patient's going to suffer as well. Because we know if we burn through all of this, there's usually not a whole lot that is going to help this patient in the short term aspect of things. Um, so again, I'm not going to dive real depth because I'm just going to go down this big, huge, long rabbit hole and end up opening up a whole other slide to show you guys what I'm talking about. But remember, epidermis, top, dermis, middle, subcutaneous is the bottom. Your nerves, veins, and arteries are what run along the subcutaneous, so they run along the bottom. Um, and if you look, you kind of have the I call them capillary feeders. It's the way that I always remembered them. Again, I know that I learned differently than everybody, but that's kind of the way that I remembered them. Um, you have your sensory receptors that just lay right under the dermis at the top of the dermis. Um, and then you get that, your skin and all that lays on the outer edge. Boom, 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 boom. Um, we cover this again in respiratory, but I'm gonna hit it again now. The more you hear it, the more you're likely to remember it. So the function of your respiratory system is to obtain oxygen for cell metabolism and eliminate the carbon dioxide. And we do this through a process called respiration. This is the gas exchange is what we refer to this as. This is where we bring the oxygen in and we get the carbon dioxide out. Most people breathe when their carbon dioxide levels are higher. We bring the air in, we get the gas exchange, we exhale, we get the carbon dioxide out. It's kind of the way that works. Um, we'll get into this a lot more in respiratory, but the other part of it is you get this thing called a hypoxic drive, and that's where certain people with certain diseases will breathe when their SpO2 gets too low. Again, we'll get into that more in respiratory because then we really talk about this is why we don't always just instantly throw someone on oxygen, blah, 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 blah. So here's a good picture of how this works. So we're bringing the oxygen in, we're pushing the carbon dioxide out of the body. So we're getting that gas exchange, O2 in, CO2 out, O2 in, CO2 out. And it's this just never-ending process. And it's what keeps our body going. So when we talk about bringing oxygen in, 97% of it is attached to the hemoglobin, 3% of it's dissolved in the plasma. When we talk CO2, 70% of it's bicarbonate, 23% is attached to hemoglobin, and 7% is dissolved in the plasma. So when we look at SpO2, we're really looking at how red the blood is, essentially. That's letting us know how much oxygen is in there. Um, you're, yeah, we're just gonna leave that at that until we get to that portion. Um, no. Again, I know it seems like we're breezing through this, but again, this is literally the most hated thing to teach just because we do it again and again in each individual chapter. So we're really going to get into the anatomy of the heart when we get into cardiology. We'll get into the valves and um, blood flow. So please remember back to basic school, tracing the drop of blood through the heart and the which way it flows through the valves. Congratulations, we get to do that again. You will learn the firing order of the heart, how it's the SA node to the AV node, um, down into this, down into these, all this other fun stuff. You go SA node, your AV, the bundle of his, the left and right bundle branches down into the Purkinje fibers, and we really get into all of that even more. So again, we talked physiology. It's stimulated by an autonomic nervous system. What we mean by autonomic is it automatically does it for you. You don't sit there and think heart beat, lungs, bring air in, all these other things. It just automatically happens. So the way that the impulse travels, it starts at the top of the heart at the SA node. It goes down to the AV node through the Purkinje fibers, and then from sorry, from the AV node down into the bundle of his through the Purkinje through the bundle branches left and right, and then down into the Purkinje fibers. The reason that this is important to know is the SA node is the primary pacemaker essentially of the heart. And if it doesn't get the impulse to fire from there, that's where your 60 to 100 is. It goes down to the AV node. That's where your 40 to 60 rate comes in. And again, we cover all this in cardiology. And it will make a whole lot more sense because I can actually get into it a whole lot better without spending 2.5 hours just on the firing of the heart. So we get into preload, afterload, stroke volume, and all that in cardiology. Um, yeah, I don't, okay, you're going to hear me refer to something as the book normal. Book normal for blood pressure is 120/80. And I say book normal because, as we know, each individual person is different. So what your normal blood pressure is may be different than mine. Yeah, I'm a bigger boy. So when people just instantly think bigger people have high blood pressure. Not true. I usually run about 117/76. Well, according to EHA, that's not normal. Um, my girlfriend, she is usually 100 to 108 systolic, and her diastolic may be 60. My mom, my mom's a whole 5 foot nothing. She usually runs 100/60 on a good day. So again, it's just all in what is normal for the person themselves. No. So we'll cover this when we get into the neuro processes and that. So we'll talk about it for a moment though. Your frontal lobes is pretty much responsible for the personality. of the stupid computer. I hate this thing. Um, of you that is responsible that is controlled by the frontal lobes. Um, when you talk about the optical lobe, that is the vision. Um, you get your spinal cord, the medulla, all this other stuff down in here. Um, one second. I'm trying to see if I still have. Um, I don't have it right easily accessible. I have a video that goes along with this, but again, we'll just cover that when we get into neuro. Um, the hypothalamus and your thalamus are two in your cerebrum, but really, the thalamus and the hypothalamus are two good ones to remember. Um, and we'll dive into that again when we get into neuro. But the thalamus is the coordination center for signals traveling between the cerebrum and the spinal cord, and your hypothalamus is what coordinates hormones of the endocrine system. Um, so when we talk brainstem, that is the core bodily functions. That's what, your heart rate, respiratory rate, body temperature, all of that. Um, We won't dive too big or too far into the cranial nerves. It's just something you guys aren't tested on. We learn it in medic school. And to be honest with you, I'm not even sure why we do it in medic school. But let's see. No, no, because we cover that later. So when we talk voluntary system, that is any nerve that is involved in an action that the brain must consciously think about to initiate. Autonomic nervous systems, we have the sympathetic, which is our fight or flight, and our parasympathetic, which is rest and digest. I'm telling you right now, these are two very testable terms throughout class and registry. Your sympathetic is your fight or flight system, and your parasympathetic is your rest and digest. Again, voluntary is any nerve that is involved in an action that the brain must consciously think about to initiate. We'll get more into that once we get into neuro, but just kind of start remembering that now. Um, no, we cover that in endocrine, cover that in respiratory, we cover that in GI, cover that in GU. Think anybody wants to see the book thing of the penis. Cover that in OB. All right. So again, please don't think that you missed out on anything um, with that chapter because we cover that more in each individual topic. I absolutely hate teaching that. And it's actually one of the things that I believe we're going to start taking out of the general educational thing and just including A&P in each individual topic. So chapter 9 is also a pretty short, sweet, to the point chapter. It's lifespan development and cultural considerations. Depending on the area in which you run, you may not have as many cultural considerations. I can tell you from my time in Youngstown, we had Youngstown truly is the melting pot of the area. You have every ethnic background, every culture, diverse cultural area. Um, Even at my Bodunkville where I live, we do have some cultural differences down there. Like when we go get Amish, I don't know if any of you have any Amish in your area. They're a very interesting religious to, or let me rephrase it, cultural groups, because depending on the type of belief system that they're involved in, um, we can't speak directly to the females. We have to speak to the male, to the female. It's just part of their religion. Some of them, the I can't remember what they call them, but like the head family person for all the families has to be there to speak to us. Um, some religions won't let a male provider assess a female. And it's just something that we have to work with. You never want to shame a patient for their cultural beliefs. It's just one of the things that we have to deal with in this job, and we have to make exceptions for. So we need to be cautious. We need to be professional, and we need to be understanding of these things. So, um, when we talk psychological development, um, this is where we start to the psychological portion of us starts to mature, and that takes place through experiences. Um, Relationships between person and social environment at different points in our lifespan. That's part of a psychological development. The more that we experience something and the more that we are exposed to something is the more experience that we get. It's the more developed we become. Think about where you're at today, with just personal interactions, dealing with people than where you was when you was 5 years old. There's a big difference there. Um, think about so socially. So the older we get, at least the older I get, more I find the less people I really want to interact with. And I know it's not necessarily true for everybody, but statistically, the older we get, the smaller friend groups that we're interested in keeping, the less that we're wanting to go out and be the life of the party. This is where we really start to shift our change. You know, now I enjoy being home with the kids, watching TV, going on family vacations. Before, let's rally and party till 4 or 5 in the morning, get up at 8 or 9 and start again. And we're jumping off balconies into pools and we're doing all these stupid things because we really didn't truly start to develop. We do have to have some exposure to other environments than what we're used to help us develop as people. Um, some of the things that we also have to contribute or think about when we talk about development. How do we perceive the information that we're gathering? How do you perceive the interaction that you had with somebody? Um, how do you interact with people? How do you cope with something? You know, how well can we communicate with others? How do we go about talking to people? How do we decide if something's right or wrong? Because just because we think that this is the right path or the right thing to do, and this is the wrong path or the wrong thing to do, there are people that have the complete opposite approach to it. What we think is right, they think is wrong. It's all in perception, you know. One of the biggest examples and things that I talk about with this is people becoming a product of their environment. So we are raised a certain way. And just because we were raised a certain way and we are brought up a certain way doesn't necessarily mean that that is the way that we need to live. It also doesn't always mean that it was the best way to be brought up or the best way for us to live. Um, Again, it's all in perception. You know, I used to be. I used to be very good friends with somebody, especially in high school. Um, and I can tell you, we was always in trouble in school. Um, we did our fair share of dumb things, And to this day, he still does because that was the lifestyle his parents lived. He became a product of his environment. Um, you know, I was never really a product of my environment when I was a kid. I was kind of the complete opposite. Now, the older I get, the more I did become a product of my environment. Um, I kind of, did that complete turnaround thing and went 180 degrees in the different direction because now the way that I perceive, my actions in the past, it's not the way that I want to be or the way that I wanted to be. So again, it's all in perception. I'm a guy. I'm stupid. I know that, you know, my brain will probably never fully develop at this point in life. Again, each individual person is different. We're different on when we mature on things. We're different on how we perceive things and how we communicate with others. And you know, we can communicate a certain way and it might make sense to a lot of us, but then the way we communicate may be wrong to others. It's it's how do I want to put this and not be politically incorrect? It all goes back to, I guess, perception is the best way I'm going to put that and leave that. Um, you know, everybody has a different expression, I should say. We have different ways of expressing our feelings. We have different ways of feeling in general. And again, it comes to exposure. It comes to the environment in which we was raised. It comes with the environment we live and work. I want you to think about how you was before you started healthcare. Healthcare typically and statistically makes people bitter. It makes us actually despise the human race even more because we get to usually see the worst of people. So this Pagets theory um, divides childhood development into four stages based on how a child understands the world. Um, it's not testable. We really don't talk about this theory. Um, and to be honest with you, I always forget about this theory until I teach. That's how little we actually never even talked about it in medic school. But there's different theories about development. There's actually one that breaks childhood development down into um I think it's 6 stages if I remember correctly. There's some that break it down into 10 stages. Um so there's this Erickson's theory of psychological development or social development, I'm sorry. And that's personality develops throughout life. And it's shaped by the resolution of basic psychosocial conflicts. Erickson's theory also talks about trust and mistrust, autonomy versus shame, initiative versus guilt, industry versus inferiority. So again, there's a lot, and I mean a lot of theories about our development. You know, some people will tell you the way you develop as a child, um, and I forget which one it is, which theory it is, but there's one out there that says the way that you develop as a child will shape you as an adult. Um, Part of me actually agrees more with that theory because it talks about, choices. You're always presented with choices in life. And if you stop and think about it, and I always say this, so please, please, please don't anybody take offense to this. I'm not looking to shame anybody. I'm not looking to judge. Um, but I want everybody to stop and I want you to think of addiction for a second. Addiction to cigarettes, alcohol, drugs, sex, gambling, anything. There are plenty of studies that'll tell you we form addictions to fill voids or to ease a pain. And every addiction has started with a choice. We always choose to do something. You know, the big ones that I always hit on are smoking, drinking, and drugs. Um, they're all a choice. You make a choice to try them, knowing that you can form an addiction. I knew alcohol was addicting when I started drinking. Um, I let that control me for a while, and then I was able to finally take control of it. You'll catch me have a social cigarette, especially if I'm drinking or I had a really bad shift or a really bad call, or a social cigar. It's one of those things. It's choices, but it's me knowing full well that one makes me want to have two, but I have to have the willpower to not have two. Um, Drugs are another one. We know that drugs are very addicting and we still make the choice to do them. And this is something that I will talk about open and honestly. Um, I did have an addiction problem to just more than alcohol at one point in life. And it all stemmed from making a choice. I made a choice to try those substances, and I knew going into it that they was addicting, and I knew that I come from a family that has addiction issues. So it was a choice on my part. Some people will tell you that addiction is in your genes, and some people are bound to become addicts. There are people out there who are very successful that they'll tell you they came from an addict rich environment and they never once touched it because they didn't want to. So, there's a lot of, I guess, double-sidedness to these theories, because they are backed with a lot of science. But also, I truly believe that everything we do in life stems from a choice. you know, like when we talk about stress will make you do things, and depression will make you do things that you would have never in a million years have done. But deep down, there's still part of us that's making a choice. So again, all these theories, and that's honestly one of the reasons I really don't dive deep into them. Um, and I don't remember really ever being tested on them. On registry either. It's because a lot of them, it's just there is too much perception involved, and it's in how you want to take it. And it's kind of hard to teach something like that because, so if we talk about this trust mistrust, I'm going to use this as an example with you guys. Trust versus mistrust. So there are some people out there, they get burned one time and they will never trust that person again, right? Now there are people out there that'll get burnt, they'll be cautious of that person for a while. Then in a few years, they may see they change and they trust them again. So mistrust is not a solid theory. Um, and it's just one of the examples we can use. Uh, so this Kohlberg's theory of moral development, it breaks it down into these three levels. There's this pre-conventional morality, conventional morality, and post-conventional morality. Um, Again, I really don't dive real deep into that because again, it's a theory. When we talk physical development, the average life expectancy is 76.4 years on average in the United States. Some of the things that contribute to that is we're not a healthy population. We smoke, we drink, we're subject to secondhand smoke. We carry stress. We typically work longer into our lives to be able to afford retirement that some other cultures and other countries. The rate of pollution in our country, we eat processed foods, we do all these things, and they all say these are all things that contribute to the life expectancy. Um, excuse me. Some of the other things that will affect your life expectancy: gender, genetics, environment, and behavior. Women typically have a longer life expectancy than men. They say it's because they don't do as many dumb things as men. I beg to differ sometimes. Physical and psychological changes occur that throughout a lifespan. Again, we don't say the same size as when we was born. That's a physical change. We, you know, don't get up and put a diaper on for the most part every day anymore because we know that we need to go to the bathroom. It's a psychological change. We rely heavily on our mother as a child. In adulthood, we still rely on our parents, but not for our survival. Um, we learn right from wrong the older we get, or at least we should be. Those are changes that occur as we get older. You know, when we're first born, we breathe 30 to 60 times a minute. Excuse me. As an adult, we breathe a third of that, 16 to 20. Our heart rate drops, our blood pressure increases, um, all of these things. Again, we'll go over normal vitals the more we get into each, when we get later on, but it's not a bad idea if you want to write this chart down or take a picture of it so that you already have it. But this just gives you an idea. These are some changes that we do go through. The older we get, our heart slows down, our breathing slows down, our blood pressure goes up. When we're born, we're cute, and then I don't know what happens after that. But a neonate or a newborn is a child from birth until 1 month of age. I'm not even getting into birth weight because I've seen babies born 5.5 pounds. My nephew was a 11-pound, 2-ounce baby. They have immature body systems, so they just crap and piss all the time. Their head is disproportionately large. That's why they're like a bobblehead. Their bones are softer and less well deformed. That's why it actually takes a little bit more for them to break. And they have two fontanelles beneath the scalp. That's why they have a soft spot. Their head hasn't fully formed. They're even cute when they're an infant, and then they start getting into stuff. I call this the devil stage. And if you look at that child's face, that's an ornery child. This just kind of gives you developmental milestones. When we really get to a year and a half old, they start getting more affectionate. They have more make believe playtime. They're able to put together simple puzzles. They're climbing all everything. They can pedal. Actually, that they can pedal a bike for some ages now.
So,
Hmm?
so I hope you're almost done.